Finals SAQ 81 Obstetric Airway Management. A. What factors may contribute to difficulties encountered when securing the airway under GA in the pregnant patient? These include patient factors, circumstantial factors, and staffing. Regarding the airway, increased fatty tissue leads to difficulty in positioning. Increased breast size leads to difficult laryngoscope insertion. Increased tongue size leads to difficult intubation. Increased vascularity and edema of airway mucosa leads to increased risk of bleeding and potential difficulty with intubation. Reduced FRC and increased oxygen consumption leads to increased rate of desaturation and reduced time to secure the airway. Reduced lower esophageal sphincter tone and delayed gastric emptying increases the risk of regurgitation and aspiration. Active labor may make cooperation with pre-induction positioning difficult. Circumstantial factors: isolated obstetric theatre may delay access to adequate help. There is potential lack of second-line airway equipment. Urgency of surgery may result in failure to assess the airway, staff the patient, pre-medicate with an acid, position correctly and assess for alternative modes of anesthesia. Intraoperative conversion of regional anesthesia to GA may be challenging. Staffing: the anesthetist may be a trainee. There may be low experience with GA for obstetric patients. There may be increased cognitive load due to the unique emotional environment and dual demands of managing maternal and fetal well-being. Knowledge of the increased risk of difficult airway may lead to increased anxiety and erodes confidence. Team factors include poor planning, poor communication, lack of awareness of other healthcare professionals about the potential difficulty with airway management, failure to warn and failure to assist. B. What measures can be taken to reduce airway-related morbidity and mortality associated with GA in the pregnant woman? This includes measures to address organizational factors, measures prior to GA, at the time of GA, and after GA. Organizational: locate labor ward theatre close to main theatres and delivery suite. Establish personnel bleed list to be contacted in the event of need for GA for pregnant women. Include second anesthetist. Ensure adequate airway equipment, including immediate availability of difficult airway trolley, staff training skills and drills, implementation of the DAS guidelines. Assess multidisciplinary protocols for antenatal assessment of high-risk patients, pathways for ensuring communication of a written management plan to the staff on duty when the pregnant patient presents in labor, guidance for handover between staff involved in obstetric care, to include those at risk of airway issues, such as those at risk of needing GA, and those with difficult or predicted difficult airway. Prior to GA, outpatient antenatal assessment of high-risk women, such as the obese, those with known previous difficult airway, and those with regional anesthesia likely to be difficult, unacceptable, or contraindicated. Inpatient intrapartum assessment by anesthetists of high-risk women, junior anesthetists to discuss problematic patients with senior to assist in development of management plan, regular ranitidine in labor for selected women according to protocol, plans for likely difficult patients to be discussed with other staff and equipment ready, anesthetists to remain aware of efficacy of epidurals in situ on the labor ward in order to increase the chances of successful regional anesthesia in emergency, reducing the need for GA. At the time of GA, plan daytime delivery with senior staff for patients deemed very challenging, team briefing of airway plan, second anesthetist present, suitable equipment ready, including full difficult airway kit, confirmation of pre-medication with ranitidine and sodium citrate, optimal patient positioning such as ramping, awareness of impact of left lateral tilt on anatomy, adequate pre-oxygenation, cricoid pressure, and auscultation of the chest, and check of capnography before cricoid pressure is released. After GA, same care with extubation as intubation. Consider stomach emptying with orogastric tube. Ensure patient is wide awake, sitting up, and fully reversed. Check with nerve stimulator. Awareness of the impact of opioids on conscious levels post-operatively, and use of opioid-sparing techniques if suitable. Train recovery staff. Properly equipped recovery. C. What are the recommendations in the 4th NAP regarding airway management in the pregnant woman? This includes difficult airway management and CICO skills must be kept up to date. Obstetric anesthetists should be familiar with the use of second-generation supraglottic airway device for airway rescue. Awake fiber optic intubation should be available anywhere in the hospital. All recovery staff should be properly trained and skills regularly updated. Overall 57.6% pass rate. The NAP4 has been the basis of numerous finals FRCA SAQ questions. Additional information on obstetric airway management. Epidemiology. For the general population, around 30% of deaths attributable to anesthesia are associated with problematic airway management. For example, due to suboptimal management in unforeseen circumstances, or poor planning in patients with known or predictable difficulties. Incidence of difficult intubation 1 in 50 overall, however in the ICU 1 in 10. Impossible intubation 1 in 200 to 1,500. In the obstetric population, difficult intubation incidence is 1 in 21. 3 out of 4 obstetric difficult airway cases in the NAP4 project were obese. Failed tracheal intubation 1 in 390. Maternal mortality 1 death for every 90 failed intubations. Important components of safe obstetric airway management includes adequate and timely airway assessment, consideration of fasting status, pharmacologic aspiration prophylaxis, optimal patient positioning, adequate pre-oxygenation, and provision of a secure airway, typically with an endotracheal tube following RSI. Airway assessment. Factors that may predict airway difficulties in the obstetric population. For tracheal intubation, this includes BMI more than 35, neck circumference more than 50 cm, thyromental distance less than 6 cm, cricoid pressure, Malampati grade 3 to 4, fixed cervical spine flexion deformity, dentition problems, miscellaneous such as OSA, reduced lower jaw protrusion and airway edema, and mouth opening less than 4 cm. Predictors for difficult mask ventilation includes BMI more than 35, neck circumference more than 50 cm, thyromental distance less than 6 cm, cricoid pressure, Malampati grade 3 to 4, and miscellaneous such as OSA, reduced lower jaw protrusion and airway edema. Factors predicting difficult SAD insertion includes BMI more than 35, neck circumference more than 50 cm, TMD less than 6 cm, cricoid pressure, and dentition problems such as poor dentition and buck teeth. Factors predicting difficult front of neck access includes BMI more than 35, neck circumference more than 50 cm, and fixed cervical spine flexion deformity. Kindly refer to the video airway assessment for further details. To reduce pulmonary aspiration risk, be aware that gastric emptying is delayed in labor and by opioid analgesia. H2RA and sodium citrate increases gastric pH and reduces harm should pulmonary aspiration occurs. Ultrasound assessment of gastric contents may be used to individualize risk of regurgitation. Patient positioning. 20 to 30 degree head-up position or RAM position may facilitate insertion of laryngoscope, improve view of glottis, increase FRC and reduces the risk of gastric regurgitation. Effective pre-oxygenation. Ensure EtO2 of 90% or more prior to induction. Fresh gas flow, oxygen 10 liters per minute with tight-fitting face masks are required. In an emergency situation, 3 to 4 maximal capacity breaths of FiO2-1 may be as effective as 3 minutes of normal tidal breathing of FiO2-1. Effective apneic oxygenation. Nasal prong oxygen of 5 to 15 liters per minute may prolong apnea time by maintaining bulk flow of oxygen during intubation attempts. High-flow humidified nasal oxygen may provide an alternative method of pre-oxygenation and/or apneic oxygenation. However, limited data exists in the obstetric population. Gastric insufflation and epistaxis are potential complications. Identify the cricothyroid membrane. Palpate and confirm the position of the cricothyroid membrane during pre-oxygenation. In the event supraglottic attempts to secure the airway fails and front of neck access is required. Ultrasound neck aids the identification of cricothyroid membrane. Regarding cricoid pressure, this is controversial as there are limited evidence of its effectiveness to reduce aspiration. There is potential to make airway management more difficult if cricoid pressure is incorrectly applied. The DAS airway guidelines recommend application of cricoid pressure during RSI of an obstetric GA. Many guidelines recommend a low threshold to reduce or release cricoid pressure if it impairs laryngoscopic view, insertion of endotracheal tube, face mask ventilation, or insertion of SAD. If a SAD is required after tracheal intubation fails, cricoid pressure should be temporarily released during insertion and then reapplied. Regarding face mask ventilation prior to tracheal intubation, this has been traditionally avoided because of the fear of gastric insufflation and risk of regurgitation. However, gentle face mask ventilation, maximal inflation pressure of 20 cm H2O plus cricoid pressure has been recommended in recent guidelines as it may reduce the risk of desaturation and provide an indication of ventilation ability in the event of failed tracheal intubation. Regarding elective use of supraglottic airway device for cesarean section, there are a number of case reports of elective use of SADs in the fasted patient undergoing elective C-section. Significant airway-related complications have not been reported in these studies. However, high-risk women were generally excluded. Regarding direct versus video laryngoscopy, for DL, short-handled laryngoscope should be available for pregnant women, as large breast may impede the insertion of laryngoscope with a standard length handle. Regarding video laryngoscopy, there is widespread adoption and VL should be immediately available for all obstetric GAs. Advantages of VL: it provides a more optimal view of the glottis, it reduces intubation difficulty, it improves tracheal intubation success rate and may reduce hypoxemia, there is reduced risk of esophageal intubation, costs are normalizing, it is advantageous when teaching trainees, and it improves teamwork and communication. Disadvantages of VL: it is not universally successful and requires a backup plan. Intubation may be difficult despite an adequate glottic view, especially when using a hyperangulated blade. Experience with one type of VL does not equate to skill with all VL. Optimal device is currently unknown. VL does not replace flexible scope intubation. VL may prolong intubation and increases risk of hypoxemia. There may be risk of pharyngeal injury. It is more expensive than DL. Routine use of VL may reduce the skills with use of other airway devices. Difficult airway management. The main emphasis in these guidelines are planning and preparation, as well as communication with the whole team. Difficulty or failure with one airway management technique is associated with difficulty and failure with other techniques. For the anticipated difficult airway, identified based on airway assessment, ensure early review by an anesthetist so that an airway management plan can be formulated and necessary equipment obtained. Awake tracheal intubation using either fiber optic scope or rigid laryngoscope may be chosen as the safest airway management. Oral route for tracheal intubation is recommended as there is increased risk of bleeding via the nasal route. Awake tracheal intubation is challenging to perform in emergency cesarean section. If a plan is made for a specific airway intervention performed under controlled conditions, contingency plans should be considered in the event the woman presents in the after-hours period requiring an emergency intervention. Prior to induction of GA, the team should decide whether the patient should be woken up or surgery proceed should failed intubation occur. Guidelines for difficult airway management includes the 2015 DAS guidelines and the Vortex approach by Crimes et al. In 2015, the Difficult Airway Society produced algorithms for airway management specific to obstetrics. Algorithm 1, Safe Obstetric General Anesthesia, Pre-induction Planning and Preparation and Team Discussion. RSI, Consider face mask ventilation with Pmax 20 cm H2O. Laryngoscopy, maximum 2 intubation attempts, third intubation attempt only by experienced colleague. Verify successful tracheal intubation and proceed with surgery and plan for extubation. However, if laryngoscopy and intubation fails, declare failed intubation and proceed with algorithm 2, obstetric failed tracheal intubation. Call for help. Maintain oxygenation with supraglottic airway device, maximum 2 attempts, or face mask ventilation. If successful oxygenation, ask whether it is essential or safe to proceed with surgery immediately. If no, wake the patient up. If yes, proceed with surgery. If failed oxygenation, declare CICO and proceed with algorithm 3 CICO. Provide 100% oxygen, exclude laryngospasm, ensure neuromuscular blockade, proceed with front of neck access. Algorithm 1, safe obstetric general anesthesia, involves pre-theatre preparation with airway assessment, fasting status, and acid prophylaxis, and intrauterine fetal resuscitation if appropriate. Adequate planning with team, WHO safety checklist, general anesthetic checklist, identify senior help, alert if appropriate, plan equipment for difficult or failed intubation, plan or discuss wake up or proceed with surgery. Proceed with RSI, check airway equipment, suction and IV access, optimize position, head up or ramping with left uterine displacement, pre-oxygenate to EtO2 of 90% or more, consider nasal oxygenation concurrently, cricoid pressure 10 Newton, increasing to 30 Newton maximum, deliver appropriate induction and neuromuscular blocker doses, consider face mask ventilation, Pmax 20 cm H2O. Proceed with first intubation attempt. If poor view of larynx, optimize attempt by reducing or removing cricoid pressure, external laryngeal manipulation, repositioning of the head and neck using bougie or stylet. If tracheal intubation fails, ventilate with face mask, communicate with assistant, proceed with second intubation attempt, consider alternative laryngoscope and removing cricoid pressure. The third intubation attempt should only be made by experienced colleague. If failed 3 intubation attempts, follow algorithm 2, obstetric failed tracheal intubation. Algorithm 2, obstetric failed tracheal intubation. Declare failed intubation. Theatre team to call for help. Priority is to maintain oxygenation, for example, by supraglottic airway device. Second generation is preferable. Remove cricoid pressure during insertion. Maximum 2 attempts at SAD insertion. Alternative is oxygenation with face mask, with or without oropharyngeal airway. Consider 2-person face mask technique, reducing or removing cricoid pressure. Assess if oxygenation is adequate. If it is, ask whether it is essential or safe to proceed with surgery immediately. If not, wake the patient up. If yes, proceed with surgery. If unable to oxygenate the patient, follow algorithm 3 CICO. Execute measures to avoid awareness and aspiration during oxygenation. Second generation SAD is recommended as these devices enable drainage of gastric contents and allow for higher inflation pressures. Algorithm 3 CICO. Declare emergency to theatre team. Call additional specialist help such as ENT surgeon or intensivist. Provide 100% oxygen. Exclude laryngospasm and ensure adequate neuromuscular blockade. Perform front of neck airway access. If oxygenation is restored, consider whether it is essential or safe to proceed with surgery immediately. If not, wake the patient. If yes, proceed with surgery. If oxygenation is not restored, proceed with maternal advanced life support and perimortem C-section. Availability of ENT surgeon or intensivist should not delay attempts at re-establishing oxygenation. If front of neck access is unsuccessful, cardiac arrest is likely, and maternal advanced life support should be commenced. Follow through ALS algorithm as normal. 4 additional requirements on top of the usual ALS algorithm includes crash team should include obstetricians and pediatricians, ensure left lateral tube, early intubation and perimortem C-section. CPR should be performed in the same way and drugs should be administered at standard doses. Perimortem C-section should be performed within 4 minutes if return of spontaneous circulation is not achieved in the pregnant woman with a fundal height at or above the umbilicus. The OAA DAS Obstetric Airway Guidelines recommends a scalpel cricothyroidotomy technique using the scalpel to make a transverse step incision through the skin and cricothyroid membrane before placing a bougie into the trachea, over which a tracheal tube can be passed. The authors of the DAS guidelines consider this to be faster and more reliable than a cannula technique in the emergency setting. Table 1 shows the criteria to be used in the decision to wake the patient or proceed with surgery following failed tracheal intubation. In any individual patient, some factors may suggest waking and others suggest proceeding with surgery. The final decision will depend on the anesthetist's clinical judgment. In the elective setting with no risk to either mother or fetus, waking and subsequently proceeding with an alternative anesthetic technique may be the correct decision. Decision depends on clinical judgment of the anesthetist in discussion with obstetric team, the anesthetist's individual skills and confidence, and the evolving situation. Unless it is safe or essential to proceed with surgery, the patient should be awakened. Strong indications for waking the patient after failed tracheal intubation includes obstructed airway, inadequate capnogram, hypoxemia secondary to hypoventilation, and a relative indication if the patient has eaten recently. Strong indications to proceed with surgery includes maternal or fetal compromise, difficulty with providing alternative anesthesia, or awake securement of the airway. If there is adequate airway or ventilation, further intubation attempts are discouraged unless a new factor presents that significantly increases the chances of intubation success, or there is an indication for prolonged airway control. Factors to consider whether to wake the patient up or proceed with surgery after failed tracheal intubation. Before induction, maternal condition, fetal condition, anesthetist, obesity, surgical factors, aspiration risk, and alternative anesthesia. After failed intubation, airway device or ventilation, and airway hazards. Factors that suggest waking up the patient includes no maternal or fetal compromise, novice anesthetist, maternal obesity, complex surgery, major hemorrhage anticipated, surgical difficulties expected, high aspiration risk such as recent food intake, and no anticipated difficulty of alternative anesthesia, which includes regional anesthesia and anticipated easy securement of the airway awake. If after failed intubation, factors that suggest waking up the patient includes difficult face mask ventilation, difficult front of neck airway access, laryngeal edema, stridor, bleeding, and airway trauma. Factors that suggest proceeding with surgery before induction, maternal or fetal compromise, anesthetist is consultant or specialist, patient is not obese, surgery is not expected to be difficult, low aspiration risk, and alternative anesthesia is absolutely contraindicated or has failed, surgery has started. After failed intubation, factors that suggest proceeding with surgery includes presence of second-generation supraglottic airway device with successful oxygenation, and no airway hazards such as edema, bleeding, trauma. Management after failed tracheal intubation. If proceeding with surgery, maintain anesthesia, maintain ventilation, consider merits of controlled or spontaneous ventilation, and paralysis with rocuronium if Sugammadex is available, anticipate laryngospasm and CICO, minimize aspiration risk, maintain cricoid pressure until delivery if not impeding ventilation. After delivery, maintain vigilance and reapply cricoid pressure if signs of regurgitation, empty stomach with gastric drain tube if using second generation SAD, minimize fundal pressure, administer H2RA if not already given. Senior obstetrician should operate, inform neonatal team about failed intubation, and consider TIVA. If waking up the patient, maintain oxygenation, maintain cricoid pressure if not impeding ventilation, either maintain head-up position or turn left lateral recumbent. If rocuronium was used, reverse with Sugammadex. Assess depth of neuromuscular blockade. Manage awareness if paralysis is prolonged. Avoid accidental awareness. Anticipate laryngospasm and CICO. After waking, review the urgency of surgery with obstetric team. Intrauterine fetal resuscitation as appropriate. For repeat anesthesia, manage with at least 2 anesthetists. Anesthetic options: regional anesthesia preferably inserted in lateral position, or secure the airway awake before repeat GA. Additional notes: when proceeding with surgery, consider whether to use positive pressure or spontaneous ventilation, whether to maintain neuromuscular blockade, whether to maintain cricoid pressure throughout the procedure, whether to continue with current airway device, or attempt to intubate the trachea using the supraglottic airway device as a conduit. The benefit of securing the airway with an endotracheal tube should outweigh the risk of potentially worsening the clinical situation. Consider using non-irritant volatile agent such as sevoflurane, To reduce the risk of airway spasms, airway management may become easier once the fetus has been delivered due to decrease in maternal oxygen consumption and reduced intra-abdominal pressure, leading to higher pulmonary compliance. The vortex approach in airway management is designed for use in a developing time-critical airway emergency and aims to provide a simple and consistent mental model and implementation tool for real-time management of airway emergencies. Maximum 3 attempts at each lifeline, which includes oxygenation via face mask, supraglottic airway device, or endotracheal tube. At least 1 attempt should be made by the most experienced clinician. Priming status escalates with unsuccessful best effort at any lifeline. For each lifeline, consider manipulations of the head and neck, larynx, and airway device, adjuncts, change of size or type of airway, suction of secretions, adequate oxygen flow, adequate muscle relaxation. Proceed with front of neck access and oxygenation if lifelines fail. Regarding extubation, focus on airway management must continue until the patient has recovered from GA and is able to maintain their own airway. Maintain vigilance. Patients should be extubated in the left lateral or head-up position with full reversal of neuromuscular blockade. Summary of important points. Category 1 C-section is the worst scenario, which may increase difficulty in airway management. Use airway assessment to predict global airway management difficulty, not just laryngoscopy and intubation. Before induction, make provisional plans should intubation fail. Either awaken the patient or proceed with surgery. Communicate this with the team. Prolong safe apnea time with head-up position and apneic oxygenation. Gentle face mask ventilation with cricoid pressure after administering induction agents is recommended. Cricoid pressure should be reduced or released if there is poor view at laryngoscopy. After first failed tracheal intubation, SGA or face mask ventilation are valid first options, and second generation SGA is recommended. Decision to awakening or proceed with surgery after failed intubation. Unless it is safe or essential to proceed, the patient should be awakened. Strong indications to wake the patient after failed intubation includes obstructed airway, inadequate capnogram, hypoxemia secondary to hypoventilation, and high aspiration risk. Strong indications to proceed with surgery includes maternal or fetal compromise and difficulty with providing alternative anesthesia, such as regional anesthesia, and awake tracheal intubation. If CICO occurs, ensure muscle paralysis before performing front of neck access procedure. After failed intubation at cesarean section, there is increased risk of neonatal admission to the NICU. Inform neonatologists. These are my references. Thank you.